Chairman, sir, my teachers and friends, I'm grateful to the organizing committee to give me the opportunity to talk on an ailment which I deal so frequently because one outpatient clinic, which consists of approximately 200 patients, 5% of the patients, they are with spondylolisthesis. This is not with me, and I believe that this also must be the people, those who are dealing with low backache, same number of patients must be coming to them also. So I thought it is apt to talk about this ailment. If we talk about the classification, if we talk about the definition, biomechanics, grading of spondylolisthesis, prognostic indicators and management, friends, you will find there are only controversies. There is no definite classification or the management as far as the spondylolisthesis is concerned. If we look into the spondylolisthesis, most of the spondylolisthesis, they do not progress, whereas there are spondyles which have the tendency to progress. Similarly, few spondylolistheses are painful, whereas the other spondylolistheses, they are painless. There are deformities present, which are known as high dysplastic, where the deformity is more, and there are spondylolisthesis where the deformity is also insignificant. If we tend to treat these patients with the fusion, most of them, they tend to respond to the fusion, but there are spondylolisthesis which do not respond even to the fusion and produces pseudoarthrosis. So even with the historical view of the spondylolisthesis, you will find that there is variation existing. So thus, if we talk about the treatment options, there is no established treatment standards. However, there are only guidelines and options. The method chosen depends essentially upon the clinical scenario of the disease and the surgeon experience. And it spans from the non-operative treatment to minimal invasive and the major spinal reconstruction as far as spondylolisthesis is concerned. When we talk about the classification, it is the Wilsey classification, which was the first, which was given in 1975 by Wilsey, McNabb, and Newman, and they classified like this. But still, there are deficiencies in this classification because it could not justify many etiological factors as far as the spondylolisthesis is concerned. This was still not appreciated, and then there was a modification by Wilson and Rothman, who added another type, which is known as a post-surgical. Now, in these circumstances, when we have extensive trauma, we see many patients, those who are suffering with a post-surgical, the trauma as well as the surgery which we do, we have post-surgical spondylolisthesis. And this is the classification by Marchetti and Bartolomei, which is most prominent classification, which satisfy most of the queries which are raised. And this is development spondylolisthesis, which could be of developmental type or ischemic type, which has type A with lysis with the pars intratocularis and subtype with the elongation of the pars. And the acquired one is traumatic, which is with acute fracture or a fatigue fracture of the pars, and then iatrogenic, pathological, as well as degenerative. In congenital or a dysplastic spondylolisthesis, in subtype A, you have axially oriented articular processes, and in type B, there are sagittally oriented articular processes, and in type C, these are the associated normally present with the articular facets. This is the one ischemic spondylolisthesis, where there is a defect or the stress fracture at the pars intratocularis. And in another type, subtype B, is where there is an elongation of the pars intratocularis. The degenerative spondylolisthesis, which is increasing because of the longevity, and this is essentially because of long-standing intersegmental instability. Traumatic spondylolisthesis, as I mentioned wrongly earlier, is more common also when we see most of the patients with the trauma, and it could be with the acute fracture or with the major trauma. The isthmic spondylolisthesis type B pars antiarticularis where it is elongated, and this is essentially because of the heredity. Sorry. So we have the pathological, if there is any tumorous condition or any disease which is involving the pedicles, will produce a pathological spondylolisthesis, and post-surgery, if we try to destroy the pedicles and produce an injury to this pedicles, will produce a slip. So in a clinical practice, out of all these cases of spondylolisthesis or the types of spondylolisthesis, we have the commonest one like the isthmic, degenerative, but less common are trauma and pathological conditions. So I would discuss with you first initially the isthmic. This is the one where there is a defect, and you are aware that there is a defect in the pars intraarticularis which produces an anterior subluxation. Last night in the president lecture, I was just wondering that a couple which was doing a gymnast probably will have a similar problem and can have a spondylotic defect and can have a pain eventually. The pathology in these spondylotic defects would be the forces which would be acting on this, like the dynamic forces, which is a gravity as well as the muscle action, and the static forces like the bone hook catch and disc. We are going to discuss on these two things. And the forces which acts like the gravity is like this, and on the right side you will see that the muscle action which produces the tendency to produce the slip. The bone hook consists of the L5 pedicle, L5 inferior articular facets, and L5 pars intraarticularis, and the catch is the superior articular facet of S1. And if you find that there is a defect in these hook and catch, there is a tendency of slip because the gravity as well as the muscle action will try to produce a slip of these vertebrae. And dysplasia of the hook and catch will increase the load on the pliable disc, which stretches on the annulus and produce a translation and the slip of the vertebral body. Usually they present with the back pain, leg pain, and the radicular symptoms. These are the common things. And on examination, you can have a tenderness, a step could be palpable, and the forward flexion would be limited in patient because of the muscular spasm. We must know what are the offending structure which produces a neurological symptoms at the site, and this is hypertrophied fibrocartilage at the level of the defect, the osteophytes adjacent to the defect, a degenerated hypertrophic facet caudal to the defect, and a degenerated herniated disc. These are the offending structures which tend to produce a pressure on the nerve and produce a radicular symptoms. In a high-grade subluxation, there is a traction on the cauda equina, and this produces a cauda equina syndrome in the form of bladder wall involvement in the patient with spondylolisthesis. One need to have the X-rays, and the X-ray like AP view, lateral view, and the oblique views, they are very important, and one also need to take the flexion extension of the spine in a standing position with a loading situation. And this is what commonly we see in a Scotty dog neck, which we see in the oblique view. In addition to this, if we wish to compare our studies, we need to know the anterior displacements, the slip angle, sacral inclination, and the sacral index. And this is like this, the slip angle, and this is the flexion extension views. We also need to have this investigation to corroborate with our diagnosis and the management with the help of a CT scan, MRI, and isotopes. This is an important thing. The important goals in cases of the patient with the isthmic is that the patient must be educated as far as the spondylolisthesis is concerned. We must be able to control the pain, and we also should ensure that it does not it does not progress as far as the patient is chilled. The various options which are there with us is whether we should operate upon this patient or we should not operate upon. The treatment could be non-operative or operative. If you are planning to operate upon this patient, whether should we do the decompression or we should do fusion, or it should be combined with both decompression and fusion. If we are doing fusion, should we do anterior fusion, posterior lateral, or both? And the fusion with reduction, should we do the fusion after reduction, or should we do the fusion in situ? And for reduction, should we use the conservative method, or should we use the instrumentation? That is why in the beginning I said there are controversies as far as the management is concerned. We need to see what is our experience and how do we do it. Non-operative treatments also exist and must be used in almost all the patients till we exhaust ourselves. And these are exercise program, braces, bed rest, analgesics. I go back to my junior residency at Banaras when Professor Tully's patients, with all patients with the backache, he will say in the OPD, give 5B to all these patients, and these were the exercises like the back extension abdominal, the bed rest, the braces, and the popular drug was butazolidine. So 5B used to be the treatment as far as the patients for low backache were concerned, but we are aware now that in addition to this, the inpatient spondylolisthesis, we need to do the flexion exercises. Traction and manipulation for spondylolisthesis, we have never done it, but since then, anything which we have taken in the OPD for patients of pain in the leg is epidural injections and the facet joint injection. It has been seen by Bengels that if there is a pain and neurological symptom despite non-operative treatments, and the slip is more and the age is less and there is a neurological deficit, these patients, they require surgery. So we must ensure in adolescents that the pain is taken care, and we must see that the predicted progression must be stopped. Whereas in case of an adult, we should, in addition to the pain and predicted progress, we should also take care of the neurological deficit which could be present among the patients who are adult as compared to the adolescent patient. So what are the options with the isthmic? They are pars interarticularis defect repair, decompression, fusion could be posterior lateral or interbody, and reduction of the isthmic deformity. And how do we do it? The pars interarticular defect, if there is no slip, we will go to the defect, we will freshen the edges, put the screw in the form of osteosynthesis and a bone grafting. See this patient who has a slip. Now there is a defect in the pars interarticularis. A screw has been passed from the lamina to the inferior articular facet to the superior articular facet after making the areas fresh and then putting the bone grafts. And this is the oblique view where we put these screws if there is no slip in the isthmus. This is another patient with a defect in the pars interarticularis, the lateral view and the AP view, and in both these patients you can see that we have put in a screws and the bone grafts. This is another patient with a defect. The screw has been put from the inferior articular facet to the superior articular facet, passing through the defect, and bone grafting has been done. This is the post-operative, and the patient is comfortable. If the isthmic spondylolisthesis is with the slip, the question is, should we fuse in situ? Should we remove the posterior loose fragment, which is popularly known as the Gill's procedure? But what we tend to do is we do the posterior decompression, reduction of the slip, combine this with the anterior and posterior fusion. I have not done any spondylectomy and anterior and posterior fusion, but it has been described that if the slip is severe, one can remove the vertebral body and then fuse from the upper vertebra and the lower vertebra and excising the slipped vertebra. This is done in cases if the slip is more than 60% and the slip angle is more than 50, and the patient has still not responded to the conservative treatment which we had discussed in the form of 5B, and then if the patient's age is between 12 to 30 years. After 92, 93, when the instruments they were available in our country, we started using this, and they help in reduction, they help in early mobilization, and the fusion rate is also better, but it has the tendency for implant failure, and the learning curve is slightly longer. The method of reductions for the slip could be traction cast reduction, posterior distraction, anterior resection and reduction, vertebrectomy, pedicle fixation, the posterior lever reduction. What we are using for the reduction is the pedicle screw as well as the shank screws of Synthes. This is a patient with a defect and a slip. The reduction and screw is fixation like done. This is a patient who is a young boy complaining of the pain in the back. We have done the fixation, reduced it, and put a bone graft from the posterior side. And this is the early postoperative situation of this patient. This is another patient of a slip at L4, L5. The slip has been reduced, and in addition to the posterior fixation, the anterior fusion with the posterior PLIF has been done by putting the cage in the. It's another patient. Most of our patients from the village side, and they are obese females. Another patient of a slip L5S1, the lysis has been reduced, fixed, and an anterior cage from the posterior side has been done. This is a young lady with isthmic. Another patient of isthmic with a slip has been reduced and fixed. But this is the way we tend to reduce with this system. And the anterior interbody fusion is also done because it has been proved now that the pain in the disc in the back is essentially because of the degenerated disc. Then in certain cases, one need to go from the anterior side and do the removal of the disc, and the cage should be put. And now it is a common procedure that with a minimal invasive procedure, in the first stage, we do the anterior cage, and from the posterior side, you go and do the fixation of the slip. The advantage of interbody spacer, the rationale is that it increases the stability when we are putting the cage from front and unload the posterior instruments, and the graft is contained inside the cage, and it improves the fusion, which makes the case as more successful. This is the anterior fusion. This is a case, another case of anterior fusion. And this is the way we treat the isthmic. And if the second commonest spondylolisthesis which we have is the degenerative, in degenerative, it is the spondylolisthesis which is with the intact neural arch, which has been described by McNabb in 1950. Newman described this with the intact neural arch as a degenerative spondylolisthesis, and the degenerative facets are the one which produces a slip. This is the important factor. 5 to 6 times it is more common among the female, those who are obese, and the age of these patients approximately more than 45 years. And the commonest site where the slip could be, it is L4, L5, whereas in case of the isthmic, it could be L5S1. The sacralization is the commonest factor associated with this, and most of the patients, they are obese. What happens is that in these cases, there are anomaly present in the lumbar facet as far as the inclination is concerned, as well as and the sagittal plane angulation is concerned. What happens is there's an increased sagittal, if you go to the second photograph, there's an increased sagittal plane angulation, which result into decreased coronal plane angulation, which produces a decreased effect on the anatomical resistance of the disc, and there is a tendency for the slip of the vertebral body. And these slips, as compared to the isthmic, the slips, they are from 25 to 30% and not more as compared to the isthmic one. In addition to this, when we see the L4 inferior facet, it tends to slip downward and pushes upon the dural sac and produces a compression as well as it also decreases the size of the canal, which produces the various symptoms as far as the neurological symptoms they are concerned. If we look into the L5 nerve root, it gets entrapped into the lateral recesses, and also the inferior neural arch of the L4 vertebra is tend to press upon the dural sac and produces the symptoms of the back and the neurological deficit. This is the way it is being pressed from posterior by from the anterior side by the disc and from the posterior side by the L4 neural arch. Besides this, if we look into the various radiological changes which are present in cases of the spondylolisthesis, you will find at L4, L5, there is a disc height is decreased, the ligamentum flavum is increased, which is producing a pressure from the posterior side. There is a disc bulge which is going from L4, L5, pressing upon the dural sac from front, and there is a stenosis of the central canal as well as the lateral canal and the lateral neuroforamen. Again, it is presenting as a low backache, neurogenic claudication, lumbar radiculopathy. The post-patient tend to get relief when he sits, when the patient walks, patient has a pain in the back coming to the leg, and this is what is known as shopping cart sign. We must appreciate that these patients which have neurological symptoms, they have the tendency to progress, and in addition to this, in the natural history, we must see that if the disc height at the level of the slip is more, this is the disc which is going to slip more as compared to a disc which is degenerated at L4, L5. Usually we prescribe the non-surgical management in the form of the exercises, essentially the flexion exercises, the braces, and we also give a epidural injection in the form of through the caudal route or through the transforaminal routes. But this is an important slide to see what is the natural history and how the patients they behave. And I was also wondering that why all the patients which have been operated, they do not say excellent after the surgery. This is a study done by Hans Moller, which indicates that if we compare the disability index and the pain index before the surgery, among the patients where the surgery has been done, among 106 patients, you will find the disability index was 48, and after surgery, after 1 year, the disability index is 29. The pain index, which was 63 before the surgery and after the surgery, is 35, and the same essentially remains in the second years. If you go to the physical, the exercises or non-operative treatment, the disability index was 44 before the conservative treatment, and it changed only to 45. That too, the disability has increased, and the pain index, which was 65 before starting the conservative treatment, it became 54. So there is some relief as far as the pain is concerned, but the disability remains essentially the same if we are treating these patients with exercises only. And that suggests that there is a place, significant place for doing the surgery in these patients. So our indication for doing the surgery is the persistent, recurrent pain in the back which is coming to the leg, neurological claudication, and significant reduction of the quality of life despite a reasonable conservative treatment, and if there is a progressive neural deficit and the blood wall involvement. The decompression which used to be done earlier, which we are not doing, indicates that if we do a decompression, there is a tendency for the slip. If the surgeon is careful enough to do not injure the facet, there is a possibility that there is a preservation of the facet which will marginally improve the results as compared to the one which is a typical Gill's procedure. The surgical decompression combined with the fusion acknowledges a best clinical results. Where should we use the instruments? If the disc height is more than 2 millimeters, as I mentioned, if the disc height is less, this is the one which is not going to slip more. If there is a presence of kyphosis, demonstrable instability, one should take a flexion extension view, correction of the listhesis. If somebody has done previous laminectomy and then there is a tendency of slip, many patients now they tend to come to the OPDs where surgery has been done 10 years before and then there is a slip, and this extensive decompression has been done more and there is a tendency for slip in these patients. So this is a patient which is approximately 75 years. Surgery for the disc has been done many years before. You can find there is scoliosis also. We attempted to do our small procedure by doing the stabilization, removing this material, and you can see that the scoliosis is still persisting. But the patient, after doing the stabilization and posterior bone graft through the PLIF, they has produced a good result. However, one need to go proximally also, And these patients can also be treated with the help of putting a cage from front with a minimal invasive and then posterior stabilization in these patients. The reduction of the listhesis tend to restore the sagittal balance. It also indirect decompression of the foraminal stenosis. And if the disc height is restored, this is very important, we must maintain the disc height with the structured or a non-structured graft, putting an interbody graft of the implant, and it shall prevent the late collapse or the implant failure in these patients. And this is which way we do. You can see in the X-ray that is the L4, L5 slip. These are polyaxial screws present in the L5, and the shank screws, they are lying in the L4 vertebra. And after this, we tend to reduce by pulling the L4 vertebra up, and in the disc space, one need to put the cage and the graft, or only the graft can be placed, and rest of the graft they have to be placed on the lateral side. After doing this procedure, one need to cut the shank screws at the top and close the wound.
Please wind up.
The fusion can be done with the T-lift or P-lift. And these are few patients. They have been done, operated. This is another patient. Minimal invasive procedure can also be done by putting the minimal invasive cage and fusion from behind. High-grade slips should be fused with the help of the posterior decompression and anterior lumbosacral using a transsacral fibular graft. If the slip is more, one can put a K-wire from both the sides, so the sacral facets, and a triple reamer is used to ream over it, and then a fibular graft is placed on the top of this. This is another patient. This is a patient, you can see the slip is more. Here, one need to cut the vertebra from the L5 osteotomy of the vertebra is done, only then you can pull it back and then put the cage and the fixation is done. This is a patient where we could not reduce much. This is can consider among the complications. In addition to this, one also have a situation like a injury to the dura. If you are going through the posterior approach, and this is a group of people working with me, the message here is that this is a common ailment among our population. A clinician which is seeing a lot of low backache, approximately 5 to 7% of the patients they are coming to this, and whenever the conservative treatment fails, one should select these patients for surgery. Thank you very much.
Thank you, Dr. RajBhadur, for your very illustrious lecture. Dr. Lord, are you here? Yes. So we'll call upon Dr. Lord to deliver